welcome to everybody to our Ezra seminar today. And I'm just noticing it's a sunny day out, although it's little flurries of snow earlier. But since we're all remote, it doesn't matter that much, I guess, to us. So first, I'm really pleased to have Rana Zadeh, who is an associate professor at Cornell, and right now a visiting assistant professor at the University of British Columbia, visiting associate professor at the University of British Columbia in Canada. But I first met Rana about 9 years ago when she first visited Cornell, and I was telling her about Cornell in general, and I think I was telling her particularly about the unique opportunities for transdisciplinary research at Cornell and how it was very easy to work between departments and do things that were not specifically very specialized in one department. And as you'll see from her talk, she's doing a lot of those kind of things now. Her background was originally in architecture, and she was a practicing architect for a number of years, involved in school and hospital or healthcare renovations, health clinic. And I don't know if that's how you got into the healthcare, whether you always had an interest in that, Rana. But anyhow, she works in very broad problems of healthcare, and particularly not just the physical things or the organizational things, but how this fits with humans in particular, how it fits in with people, both people doing the work and how they do their work, and also the people who are the patients or clients, whatever you want to call them. And so Rana is the co-founder and co-director of the Health Design Initiatives Lab here at Cornell. And last year, as you may have noticed from the announcement of the seminar, she spent a year both at Cornell Weill Medical School and then at the World Health Organization, called WHO. And we'll hear her general thoughts on this subject of systems engineering integration in healthcare. And I assume we'll also hear some interesting things about what she did last year. So, Rana Zadeh, thank you.
Thank you, Al, for introduction. So I would like to share a few very anecdotal experiences today around the topic of systems approach and healthcare through the kind of along the lines of personal, community, and global experiences. So as Al mentioned, we work together with students and faculty at the Health Design Innovations Lab. Health Design Innovations Lab, we take a systems approach. And so because of that, we work across disciplines. So we work with engineers and clinicians. And here you see taking environmental engineering approaches to solving problems. In this image, you see the meeting with the clinicians on the day-to-day challenges and questions. So taking a more ethnographic approach, understanding the user's perspectives. So taking a systems approach, we try to address critical topics of healthcare. So as a result of that, we, as Al mentioned, we really invest on the multidisciplinary angles of our institute, Cornell University, and Cornell Engineering, Design, and Environmental Analysis, while Cornell School of Medicine, our Policy Analysis and Health Administration Department, and our Nursing School Alliance at New York City. So we, each of our projects really involves students or participants from all of these disciplines so that we can generate conversations that are relevant to practice. So let's pause for a second, because all I want to share today is kind of approaching from a systems perspective. So this would be my questions to you all, and you can write in the chat, what is systems approach? What are the components of systems approach? So I'll start, and then you guys might continue on, again, adding conversations to the chat. The first and foremost aspect of systems approach is starting from the user. So basically focusing our effort and starting the conversations from the customer or from the user perspective. But there are many others. So as you guys take on this challenge to write about systems approach from your perspective in the chat, I'm going to share some of my observations. And this talk is really my own experience and my own reflection of the past 8 years in kind of various projects. So really the first step is about unlearning what you know, and really putting yourself at the shoes of the user and stakeholder and really understand what their experience is. What we call this an ethnographic approach of absorbing information from the user and being the learner. Really focusing on the needs of the user is the focus for innovation. And in systems engineering, that is very much highlighted. So when do we use a systems approach? When we face complex problems, wicked problems with many dimensions, systems approach can help us develop successful and well-integrated solutions to address these needs. So that seems to be a perfect fit for healthcare because healthcare is such a complex problem. Let's see what you guys shared in the chat. There are some other angles in the systems engineering that I would like to talk to you about. Yes, it's an entire system problem, a method of design or integration that evaluates and capitalizes on capacities, each component of the system to ensure reliable and robust design. Excellent. Thank you, Ethan and Sabah, for sharing. And feel free to comment in the chat. I'll continue to look at the chat. Exactly. So one other angle that Ethan mentioned is looking at ensuring reliable, robust design, accountability, sustainability of the solutions is another angle for systems approach. Looking at all stakeholders, not just one, is a unique characteristic of a systems thinking approach. Considering multiple disciplines, not just from engineering, not just from medicine, not just from social sciences, is another unique characteristic of a systems engineer. So, and then from all those information, feeding that into explaining what the functional requirements of a solution is, developing that solution into an output that can come to market, that can be validated, and then, as Ethan mentioned, hopefully becomes a robust, sustainable solution. Also, systems approach examines relationships and interfaces among parts and components of the system. And that's a very important characteristics of systems thinking. And hopefully, if things go well, you want to think about implementation of this, change management, transformation path that usually systems engineering takes into consideration. So thanks for sharing your comments. Feel free to, if you agree or disagree or have additional thoughts, add in the chat box. So today I have 3 takeaways. I hope we go with these 3 takeaways from this talk. The first one is when approaching health and healthcare, when providing solutions from health and healthcare, whether you come from an engineering background, an architecture background, a clinical background, it's important to really recognize, to be successful, that health and healthcare experiences and systems are quite complex. So hopefully by the end of this talk, I'll be able to convince you about how many facets that has and how it interacts with multiple stakeholders. The second component I would like to share is really innovation in healthcare today really relies on translation of available cutting edge technology, available research into practice. So much of the innovation comes about what is already out there and what we know into real life, which is a huge gap, as we know. The gap between what we know and what can be done is wider than the gap between what we know and what we need to know, according to World Health Organization's publications. So systems approach is a unique field that helps us bring these to practice, bring solutions to practice. As you guys know, in many fields, including this one, like decades are a gap between when we know something and then when it can become available in practice, so all of us can benefit from it. And lastly, yet not least, in a healthcare systems approach and systems thinking, you can be successful. You guys who are becoming systems engineers, you can, if you are going to healthcare, really you can contribute at a valuable level if you really kind of integrate this with the social behavioral sciences and understanding of the human experiences and the human basically social psychological angles. So it really has to become both engineering and social sciences together. So when we say healthcare, experience of healthcare, how was your healthcare experience? Someone asks you, or a friend who had just a surgery or a service, and they may say, oh, I had a good experience or bad experience. That simple sentence really relies on so many angles. A healthcare system or experience is basically a amalgamation of the parts and agents and interfaces, including infrastructures, policies, resources, habits, and then the agents, caregivers, patients, and all the other players. And those people are bound to their knowledge, to their belief systems and cultures. And then just for stakeholders alone, you can talk about the government entities, the national, international entities, all the way to non-governmental entities, the health ministries, the local providers, all the way to caregivers, community providers, and families, all play a role, and as a whole, they provide the care experience. So it's really a big system, really a complex system. Just to tell you how a simple experience, how diverse it can be, I want to share this study that we did between 2013 and 2016, that we wanted to know, what does quality of life mean? How do you define quality of life, a good healthcare experience, to patients who have advanced illness, who have illnesses that are quite advanced? And what does that mean, a good quality of life experience? So after doing an ethnography, after doing a user evaluation, we asked this question: what does quality of life mean to you? What brings you quality of life? And we collected 3,000 statements from all stakeholders, and we analyzed them. And interestingly, we found 6 categories combining many different angles and many different disciplines. So for example, the clinical experience became my baby here, just this part of this component in terms of symptom management, medication. That becomes one of these 6 components. But take a look, how many different angles are here. The facility, the technology, the education and training, the way people treat you, the organization, the policies, the programs, how they have access, their scheduling. Even interestingly, the philosophy, how the solutions are individualized per people's diverse cultural and religious background was a part of the quality of care experience. So when we say it's not just about medication, and clearly for the user, if we really put ourselves at the shoes of the user, and it's not just about the clinical aspect, but it's about an array of experiences, as you see, from hospitality ranging to management, to design, to clinical practices. So when you look at this only from one angle, for example, really when you look at it this way, you see that the edge of disciplines become blurred. Disciplines have no meaning anymore, because to the user, it all becomes one experience. So really, truly looking at it from a user's perspective shows us a very colorful array of solutions. So this, I'm just showing in this bar graph, study the same question: what does quality of life mean to patients with advanced illness, in this case cancer patients, was asked by clinicians based on a survey that included clinical measures like feeding, medication, social work, therapeutics, and hospital treatments. And what they found was only about 20% of what was defining what really the healthcare experience and quality of life was for the user. So really, underlining all of the rest of the disciplines that work together to really complete the piece of the pie. So hopefully that really hit home for you guys that healthcare experience and healthcare quality can be as much clinical as non-clinical, as much hospitality and environment and design and technology as medical, and a combination of all that. Now I want to take a moment. Let's take a look at the current state of healthcare. Show of hand in the Zoom. How many of you have seen this chart recently? It shows up a lot in the news or different media. The chart talks about, or information talks about, total number of mortalities annually in the United States. So let's look. The number one cause of mortality is heart disease and cancer. As you guys see the numbers right here, it's computed total, and here computed per 100,000 patients, 100,000 populations in US. So you see around 650,000, around 600,000 heart disease and cancer, unfortunately, is taking life annually. Every year we see that. And then the third one is fascinating, which is really accidents. Oops, something in the system failed, right? And that's the third cause of death, accidents. And what that means is falls, poisoning from maybe opioids or medication or other substances, or road accidents, etc., or healthcare accidents, all combined. And then after that, you see coming down to other sorts of, and then you see here communicable diseases are showing up at the bottom and so forth, and then mental health and behavioral health issues. Now, we all have been watching the news about COVID, and you guys see that COVID has been climbing up this ladder this year, and it is expected by the end of the year, if the current trends continue to be, that COVID to get close to the third leading cause of death in the United States for this year. So these numbers are 2018. This year might be a little different. But as you see, a communicable disease like COVID, which is gaining so much attention, which is very important in our lives, it's changing our lives to a great extent. It's to the scale of what is really at stake for us and what is threatening our life and quality of life still is a small portion compared to the large issue we are facing. Now, many of these, you might think, oh, well, these are maybe non-preventable, but that's not the case. Many of these mortalities are preventable. Heart disease and stroke, major portion of them can be prevented by appropriate blood pressure management. Cancer can be prevented by appropriate screening, and lots of costs and also burden and suffering can be prevented. In terms of diabetes, deaths, amputations related to diabetes, blindness related to diabetes can be prevented. So we face these numbers nationally and globally, and there's a lot to be done to improve these. And but one thing, yes, we are facing the COVID crisis, and it's really important that we take that into consideration because it's affecting our lives. But also it's very important that we look at the big picture and also see the other angles that we can continue to pay attention to as we have the spotlight has turned on our health. It's really important to see that in the bigger picture in terms of communicable and non-communicable diseases. So non-communicable diseases are still the leading cause of death for us. And these tables do not show the burdens and sufferings that are not resulting in mortality. So 400,000 hospital-acquired infections, 2 million days of lost work days annually for healthcare workers because of injuries, turnovers because of burnout, $800 million annually. So these numbers are not really reflected. So there's a lot to be done in healthcare system. So hopefully I made the case for you that we have a system that has a lot of potential for improvement, that being addressing our both aspects of communicable but also non-communicable disease and quality of life. So this information about the state of healthcare is not hidden to us and has been pretty clearly highlighted for years. It's very good that media is bringing attention to the topic of health these days, and we have to continue this momentum to bring more awareness. As you guys see, Agency for Healthcare Quality since 2006, 2013 brought to us attention to transform, importance to transform healthcare and the issues that we are facing. And they specifically discussed that 50 to 90% of the waste in healthcare can be prevented. Just to give you guys a little perspective, about $3.5 trillion US spends on healthcare annually, 3.5 trillion, that's 1/5 of the US economy. And according to Health Affairs, about 50% of this can be waste. 50% of this can be waste. And that can be inefficiencies, errors, loss of life, mortalities, or early onset of disease and suffering, that unnecessary and avoidable. So there's a lot to be done. Hopefully I made the case for you for the importance of systems engineering approach to be combined in solving healthcare problems. Now at Cornell Systems Engineering, we take our skills to many fields, from aviation to transportation to environmental engineering to healthcare. And it's very, very important that we learn from these fields and we really more seriously tackle these conditions we are facing in healthcare. Not just because of these statistics, but because these statistics, every single one means something to us, our families, our own experiences. We go to the hospital, from every 10 person entering a hospital globally, one of them will be harmed instead of healed. So that means from the crowd we are here, so a number of us will be affected by that, and our loved ones. So this becomes really a matter of personal, family, and quality of life and quality of health. So with that background, I wanted to share with you how important that is, how such a big opportunity we have to utilize the potential for systems engineering to address issues in healthcare, especially that we have an aging population across the world. Almost every country is facing that. And now that brings a lot more challenges in terms of costs and quality. And we really have to bring these efficiency measures, quality, accountability measures to the experience of healthcare. So from that angle, that was my introduction, but I have 3 examples from this experiences I have had in the past 8 years that I thought they're from different scales, but they all have common themes that I want to share with you. I'm going to pause for a second if there are any comments or reactions or reflections. Okay, so 3 examples I want to share with you. One is at the community level, and these are examples that students, myself, and colleagues we have been participating in. And one is at the global level, my observations and learning from my experience at World Health Organization. And then the last one is at the personal level, at the family and patient level. So the first one is about infection prevention. We all talk about that these days. So in healthcare, what is interesting, so we started this in 2013, and we looked at infection transfer. When people seek healthcare, it turns out that about 2 million patients every year go to healthcare and come back with a bug. So hospital-acquired infection, and it is estimated that 90,000 of them die annually, which is really a striking number, and estimated 28 billion to 45 billion loss annually. So these are the numbers that we have become numb to, but they are really significant. And so my former student, graduate student Jeffrey, and I looked into this. The first thing we did was we did a literature review. What causes infection transfer, right? So it turns out there are 3 pathways, and contact transmission is one of the most common pathways for infection transfer in healthcare, and the most effective solution based on evidence to intercept contact transmission is simple hand washing. So if we enter healthcare as family members, patients, and caregivers, and care providers, if they conduct hand washing, they can prevent major parts of infection transfer. It turns out, what do you think is the compliance rate with the proper hand washing? Let's say 80%, 90%, 50%. What do you think is a guess? You want to put it in the chat? What do you think is the compliance rate with appropriate hand washing so that the contact transmission is avoided?
Yeah, just take a guess, everybody.
Oh, good. Okay, we're getting good guesses. As you guys are thinking, either in the chat or by yourself, well, it turns out, thank you, Ethan, that was a pretty daring number, and Philip, great. Yeah, so they say, they think about 30%. Well, some studies says 30, 60%, but we know they're very much underreported. So we know that most people do not comply with something that can save life most. Yeah, so those numbers could be very much true, and studies are usually underreporting these numbers. Hand washing compliance is quite low. This photo on the left, we were invited, so we hold the innovation series every year in the spring, and we partner with the healthcare system, with the students and faculty. And in 2014, we joined a Center for Excellence in New England area, and they asked us to improve patient experience and safety. As soon as we entered the emergency department, we saw this photo on the left. What do you observe in this photo?
It looks like 2 guys that are against walls, but nobody can reach them.
Exactly. Why do you think there were 8 of them in this emergency department? The number was computed based on the use, based on the population passing through. So they thought 8 of them are needed. What was the facility manager's mistake here? Yeah, it's no space to use. They piled them up all at the same location. So does that really work? Are we really successful if we provided this, the way we implemented it to work through this? So here's what the students did in the consultation with this Center for Excellence. They ran a simulation study. They predicted what areas using space syntax methods are most visible and most crossed paths. And they recommended placement, replacement, and strategic placement of hand sanitizers at points of use. So I wonder how that changes the usage and behavior. Any guesses? So Jeffrey, my former graduate students, and I conducted a research study at our community hospital, and we studied basically the visibility and the accessibility and the placement of these hand sanitizers and their usage. And we found that actually it does have a significant difference whether or not you put them in places that are visible or accessible or not. So usage would go up, and traffic passing by would actually utilize if they saw it and if it was available. Just a few weeks ago in my class, Cornell students conducted another study, what Ethan mentioned about signage. As you see this visuals on the hand sanitizers in Cornell campus, actually, they are finding patterns of the students actually utilizing them or not by either visual or basically signs or messages. So now let's think about infection prevention as an epidemiologic perspective, and the solution being in design, engineering, and facility management. So for this intervention to come into play, to come into impact, we really need all of these to be thought together. So what happened a year after, this kind of is like a story, it goes on for a few years. So a year after, we were contacted by Director of Neurological ICU, Dr. Matt Fink. You see his photo right here. Dr. Fink reached out to Cornell engineering, design, schools, and medicine, and he said, let's take a systems approach to neurological ICU. Let's take a systems approach to healthcare. We provide excellent care as physicians at the top of our field. However, systems engineering systems, technologies, and environments lagging behind. We need to have an integrative approach. So we gathered a team of students from engineering and design and management and medicine, and we started working with them from a systems perspective. The students came up with many innovative solutions to improve patient experience, to improve safety. From about 50 ideas that was presented, that was well received, one or two of them we were asked to continue further on because it was very cost effective but extremely important. One of them was hand washing compliance. How do we make sure these very busy clinicians actually take steps to wash their hands, to sanitize their hands, either utilizing alcohol hand rubs or washing their hands? It turns out that the compliance, as you know, it's very low. So what does the hospital do? The hospital follows them, watches them. Maybe they are penalties if they don't wash them. They are invisible observers. So that is the way that currently is mainly working. So the team of students came up with technological solutions and design solutions. And they said, okay, let's think about incentives. Let's think about from a social behavioral perspective. Let's think about from behavioral economics perspective. Let's remind them. Let's reward them. So utilizing light systems, utilizing visual elements, making sure that they have these reminders in place so that space and environment is conducive to that experience. So a year later, we got a small funding. Professor George, a group of systems engineering students, mechanical engineering, electrical engineering, human behavior and design, with participation of Drs. Calfee and David Berlin from Weill Cornell School of Medicine. We took those into even further development of those ideas. As you guys see, so many sub sandwiches, and 9 months later, the students now took this to the next level, studied the functional requirements, studied the users, studied the problem, created concepts that really look at all these angles and interfaces, and they came up with a few solutions, that being visual reminders and also smart supply cards that would facilitate the process. So it took a little bit of a different turn after they really studied the topic with the users, and then they advanced it into developing functional diagrams to take it to the next level to practice. So one thing that my observation is really, again, the fields really blur here. The engineering works really hand in hand with the clinician, with the nurse, with the designer. Everything has to mesh together. So that was kind of our community experience with the students and faculty. The second experience I want to share with you is basically more of my global learning from my interactions with WHO or just working in the past several years. And I think it really beautifully summarizes beautifully here, person-centered integrative health systems are the future. So really systems marriage into healthcare. I am summarizing materials from Dr. Nuria Toro Polanco, from a WHO expert from health systems. And when he explains the current situation of healthcare system globally as fragmented and restrained, with lack of access, with lack of quality, again, globally, we have almost half of the healthcare expenditure going to waste. We have unnecessary death, unnecessary preventable suffering that we can avoid. So the solutions that WHO is providing, summarized here in these bullet points, really reminds me of the definitions of systems approach. Because again, it talks about, well, we have to be integrative. We can no longer continue with fragmented processes. We can't afford it. We have to work together across the disciplines and also put the person and the user in the center. So these are by WHO the definitions of transforming healthcare to the new generation. And the one on the right that you see is WHO's graph for transforming healthcare. It's one of their beautiful graphs. And you see coordinating services, empowering and engaging people, creating a connection among stakeholders, really conversing on the systems in approach language. One very interesting observation I had from my exposure to WHO's work, which was really striking, was WHO no longer provides recommendations that are single interventions. They are all multi-component solutions. And that is really fascinating because multi-component solutions means they're not just medical, they're maybe training, medical, technological, environmental, they all come as a package. So already based on research and evidence, we know, scientists and researchers, we know that single interventions do not work anymore, and they're not sustainable. For example, for infection prevention, when Jeffrey and I did the literature review on how to prevent hospital-acquired infections, we found education was one solution, facilities and technology was one, penalties and incentives was one. So there were many levels of solutions. But which one do you think was most effective, what the literature review found? Again, my question to you, for preventing infections, which one of these solutions you think are most effective to actually prevent infection transfer? Education and training, knowledge transfer, evaluation and feedback, facilities and environment, technologies and tracking, and so on. So which one do you think is most effective? Take a moment to think about that.
All of them together.
Exactly, that was the finding. Most of them alone are not sustainable. Some of them last only 2 to 4 weeks to a couple of months. Education, for example, and that is proven from other research examples as well, not just in infection studies. Exactly, only if all of them work together, they are truly most promising. So it was really interesting for me to see at a global level, WHO's recommendations is coming to become integrated. And that means seamlessly working a physician, a social worker, an engineer, a business person, a management, a training, an occupational therapist, an environmental scientist. They all really have to be working together to provide the solution, for example, for an older person at home. So they all really become a system solutions. How much time do I have, Al? Maybe.
You have about 16 minutes or something till the nominal end. We usually let questions run a little bit over, but basically it's supposed to stop at 12:15.
Okay, good. So I have only a few more slides to share. Thank you, Al. So I love this model by World Health Organization, and I wanted to share this with you. It's a very well thought and comprehensive explanation of health and healthy aging. As you guys, as I mentioned, because of the aging population, healthy aging is becoming a major focus for World Health Organization. And you might be aware that we have the Decade of Healthy Aging as an initiative supported by globally by all member states, initiating this year for the next 10 years. All member states and countries, governments, and health ministries and civil societies and communities are committing to next 10 years to transform health and healthy aging for older people and for aging. So this is becoming a major focus in healthcare. And this beautiful diagram shows the interplay and interfaces of different components, different parts of this system. Healthy aging being defined as functional abilities of a person being impacted and influenced by the person and their environment. Take a look at the environment. Environment is such a robust definition. Products, technology, natural and human-made environment, attitudes, services, systems, and policies, even cultures, habits, everything plays a role. And how do you really make a difference becomes you really have to take all of this into consideration, all of these angles. And obviously the other one, the individual's cognitive, physical conditions, another one. So one last thing I want to mention before I move on from a global perspective is all the stakeholders we described early on in definition of who's involved in healthcare, all the stakeholders from the family member to the patient to the local home healthcare aide to the nurse at your neighborhood to the community, everybody, and even media and the government and the ministries, everybody is involved in the experience. And if my cultural or habitual experiences or knowledge is not really conducive to changing my behavior toward better health, it's going to be really hard to change that. So really all of those play a role. And when you think systems, you really have to consider all of those angles into perspective. So WHO considers these stakeholders like media as proponents to provide information to create a good foundation for change. So COVID has been an unfortunate event. However, it has raised our awareness to health, and hopefully we will invest on this to better take this to the next level in terms of reducing some of the other harms and sufferings, premature deaths or early onset of disease that are preventable for ourselves and for our loved ones. So I'm about to wrap up. The last experience I want to share with you is more at a person level, not at a global or system level, but at the person level. And this is within the context of a project we just starting. So I'm just only sharing a little bit with you guys because we're just starting this. So this is it's called HOPES program, a program in our local community for older people at home who have dementia. So this is about improving their experience with medication management and our attempt to take our experiences and learning from systems approach to help really transform this and be successful. So 6 years ago, I had to battle with this personally. My older uncle was diagnosed with kind of advanced dementia. He was living at home alone, and we were very far away from him. So we were trying to find a way to help him manage his medication. So this photo I show you, I started 3D printing various types of medication management systems to figure out how can we really help with the cognitive decline he was having, with these issues he was having. How do we help him make sure he has a calendar, he figure out what he has had already and not, because we were experiencing a lot of issues when he was taking double dose, making him prone to falls, to loss of sleep, or it was pretty dangerous that he was missing dose or double taking double doses of these medications. So later on, after looking at this field, I realized now in 2020, that 6 years ago, that personal experience, I realized this is really a huge problem. Medication management at home, especially for older persons who are experiencing loss of cognitive functioning, like planning and management, remembering, these are important cognitive functioning for medication management. And did you guys know that older people, those who have dementia, are actually they have more medication that require that are very sensitive, like opioids. Sometimes they have double prescriptions, more they have twice more prescriptions than those older people without dementia. So that makes the situation even worse, because now for these people it's harder to manage. And now a major portion of statistics on ED, emergency department visits and hospitalizations, have been for older persons, or a prescription to an older person utilized by themselves or a child, unfortunately resulting in a serious accident, some causing death or major suffering or hospitalization. So this is a major problem. Controlled substance, important critical medication for folks who have chronic illness or older persons not being successfully managed has become a problem. And this number of hospitalization ED visits doubled in the last 5 years for older people with community dwelling older people with issues with medication mistakes. So we just recently got an NIH grant, and with the support of NIH partnership with our local community visiting nurse service, we are going to take the systems approach to try to tackle this problem. So for a geriatrician, for a physician, when they prescribe the right medication for the right diagnosis, that's the first step to success. However, that's not where health and healthcare stops. How do you ensure that person is actually complying with the prescription? Now that becomes an engineering and a design question. Now that becomes a social behavioral health question. Now that becomes a multidimensional question. So we are going to take a systems approach. We are going to study the cognitive processes for dementia and Alzheimer's. I understand what components of it, planning, remembering, needs a little bit of a nudge. And next step, we are going to, as I said, the systems engineering asks us to talk about the user, to learn the user. So we are going to have focus groups and interviews with the care providers who are providing care for older adults with dementia at home, with the folks with dementia at home and their caregiver and their family members and caregivers. So their inputs will be collected and their environment also will be studied. Their home environment will be studied. We gather all that information, and then we are going to write the functional requirements for what is needed to solve this problem. And we're going to provide a technological and educational intervention so it's a package. HOPES is a package of educational and technological intervention to help nudge and assure that medication prescription is as close to what it needs to be done. So that's our attempt to take the engineering and social science and design approach to improve the continuum of care for our most vulnerable population in partnership with the local communities. So these were 3 examples of kind of stories that came up in the past year. Some of them I thought were interesting, I shared with you. But really the takeaway, personally, I think systems engineering and systems approach can help us address a major gap in healthcare. And that it's not what I say to you, it's not new. We all know that, research, but we just have to continue pushing this and make this happen. It's focus, all of the examples I shared with you, the focus has to be on the user, not on my discipline. I used to be an architect. When I approach my users about quality of life, if I ask them about the environment and my field, I might not be doing them a favor. So it's all about them, not me or my discipline. It's about integration of multiple components, understanding multiple components, understanding the interfaces of the multiple components. What's the role of culture, habits, and diet? If I want to change diet, how can I do that if these are not really integrated? Really, these interfaces can be technological, environmental, or psychological, or behavioral, or in between. So innovation really can become possible by bridging the gaps among disciplines with the health systems approach. And then really the innovation lies in translation of what can be done, bringing available solutions and engineering to change the experiences that people have at personal level to receive care and to get well, and looking at all stakeholders. So that was my summary presentation. Thank you.
Thank you, Rana. And the floor is open for questions, which you can either do by unmuting yourself and speaking, or I'll try to watch the chat. There's probably most of it. It's a small enough group, and I think it's probably best if you just unmute yourself and ask any questions you have.
I had one. I wanted to get your thoughts on, first of all, thank you. It was a great seminar, and I very much appreciate it. It's very relevant. I wanted to get your thoughts on a concern that's been brought up about medical coding and how that has the potential of skewing the data for some of the work that you're working on. Skewing the data meaning, it would lead you to believe one area is of high impact, where in fact it wouldn't. It's actually in another area.
Can you elaborate a little bit for me? Medical coding.
Yeah, so one of your earlier slides was the CDC slide about the leading, cause of death for Americans in 2018. There's a recent claim that came up in the number of COVID deaths where at least 10,000 of those 200,000 were individuals that were already in hospice care before they passed away, and so therefore skewing the data of COVID deaths. And so I wanted to, if you had any thoughts on that, that's fine. If not.
Thanks, Ethan, for your great comment and question. So there is no news that data has flaws. So we don't have perfect data. We never have. None of the data we have is perfect, just like the ones that I shared with you. We already know they're underreported, not measured accurately, but these are the best data we have. So yes, there are many really layers to that, but I want to reflect on your great thought based on some experience I learned at WHO. That was, don't look at this data as a whole globally. That's what I learned from them. Only this data can be really interpreted at a local, regional level, because these numbers really change, right? These numbers change for a certain population or another. For example, what the chart that I showed you, mental and behavioral health and suicide was at the very bottom of mortality. But actually, if you look at the young age, 30s and 40s, that becomes actually one of the leading causes of death. That is, I believe, the first cause of death. So, and then after that, so suicide and homicide is the first cause of death. So when you change the age in the life course, the paradigm completely changes. That I just give you this as an example as when you reflected this, with the pockets of regions also have major differences. Developing countries, various regions, and even parts of our own country have different values and numbers and statistics. So it is a very good point to be critically looking at this cumulative data, because really to act on that data, we need to unpack that for that region, for that population. And then we see then what can we do that really, so it doesn't mean exactly, as you said, like, if that is the trend globally, if I just put for you the global, WHO, what I learned, what absolutely we can't generalize, right? We have to specifically talk about, let's talk about long-term care facilities and the role of COVID and the loss of quality of life and life just for long-term care for just that bracket. And then let's talk about that, the specific regions we're talking about. And then let's talk about that for outside long-term care, because then the topics and the challenges and the issues really vary. And then when we merge them together, sometimes the main kind of crux of the matter is lost, if summarized.
Thank you.
Thank you, Ethan.
Pete, I see that you're unmuted. Do you have a question?
No, but thanks, Al. It was a great talk. Thanks a lot. It's really glad I tuned in. Appreciate it.
Thank you, Pete. Thanks for
Yeah, my job is to stay healthy. That's for sure. So I'm not one of your statistics.
Rana, I have a question about the interfaces between things like social sciences, engineering, healthcare specialists, medical specialists. How do you have experience in that area, and I don't. But those are, I see they're extremely important, but what can you do to facilitate those to actually work? In other words, if let's say you know there's a problem that it needs some kind of technology, and you also know that the adoption of it will clash with some kind of social science, social norms, or something like that. What's the best way to, or what ways would you try, or how should a person try to connect these things up when you're talking to people who come with completely different narrow specialties?
Mm-hmm. Thanks for a question. And Al and I have been working on this for, I think, 8 years, right? We're trying to get through these layers from engineering and design kind of together. But I want to quote Dr. Nuria Toros on kind of talk on your response. She says, there is no shortcut in transforming healthcare. It takes perseverance and patience and hard work. Yes, it's going to be very hard to get through all those levels. But, really, there's no shortcuts. But that brings me to the core topic of what we discussed. The only solution is to bring everybody together, all the voices together, the kind of the systems angle. Because if we don't, then there's really no path forward. But when you take the systems approach, when you bring the user's voice early on, when you engage all the stakeholders, now you are motivating them. Now you're including their perspective into the solution, and change can follow. And change can come with time. Knowledge, awareness, generations, media, everything. But without including all the stakeholders, without including all these angles, that's why we have been experiencing such huge waste in healthcare in terms of number of deaths, 90 to 150,000 deaths annually in the US. This is an old statistics just from errors annually, just by mistakes. Oops. And that's just the death, not the loss of mistakes from surgeries, mistakes from infections. Those add to that. And that is why we are facing this problem, because this is really a complex and multidimensional angle, as you see here. So we have no other choice than work together from social behavioral sciences, engineering, and medicine to bring the eye to understand the health scape, to understand the behavior and the potential for behavior change, and to engineer solutions that come to the market, that are funded, that are working reliably, and that hopefully become available to the user. And so there are so many barriers here that we, with resilience and as Dr. Taro said, with basically patience, there's a path forward, and we see slow change, but hopefully with our systems engineering students and next generation, we have this accelerated.
Thank you. Anybody else?
Rana, yeah. Sorry, Al, go ahead.
No, go ahead, Pete.
Well, on this stakeholder visit, to me, you're repeating what every discipline seems to be saying, and that is we got to get the stakeholders together to really come up with a sustainable and robust and resilient policy, whatever. I'm in the environmental area, and we say the same thing. One of the big issues is, though, that how do you get people to want to come to the table unless there's a crisis? Unless they see it in their best interest, because everybody's busy. And every political system that I know of, they get credit for solving problems, not preventing them. I mean, if you want to get a statue of yourself, you become a general and win a war, right? Don't prevent the war, but win one. I'm being facetious, but that's an issue. How do you get stakeholder participation? And how do you keep them at the table? And new people come in and they have to be educated, and it's a really big issue, I think.
Exactly, and each stakeholder has their own stakes or interests,
yes.
Right? And not all of them overlap. And if you have a great solution, I teach a class called Policy Meets Design. We talk about change. How do we become agents of change? If we know good science can change lives, how do we help bring this to practice, bring this to the attention of the policymaker, to the practitioner? And really, each stakeholder has their own kind of interest. So how do we identify those interests and maybe start from the overlaps? And hopefully that would that incentives and overlaps could be a path into change.
When you were at WHO, did you observe or get involved with turf battles? WHO having their interest in wanting to get credit for what they do as opposed to WMO or UN or anything like that. The reason I ask that is my experience with the UN and the World Bank is there's always that in the background. Who's getting credit for what? And who's getting, because each agency wants to get as much of the budget that's available to them.
Yeah, exactly. And so it is really everybody has for their survival and continuation has their own specific interests. And how do we find a common goal? But everybody also has issues and goals, like burning topics. I noticed that in collaboration with local community providers and representatives, that was being nonprofit representatives, state representatives, local providers, or practitioners within the same healthcare system, their interests sometimes do not quite overlap, but also they do have some common goals as well. So when you approach this from a kind of an ethnography perspective, and you say you start approaching this by not being the expert, but just unlearning everything and going in there and listening and collecting data and understanding what keeps everyone up at night, what is their goal, and how can the new solution fit their goal and then become a whole system of solutions. And how can you really address the solution from that angle? From a business, like if you want to improve patient care experience, that's an example that my students, a couple of them are here, always talk about. If you want to improve patient care experience, you have to spend money. If you're sitting in the C-suite, you have to cut costs. So here you go. There's a first conflict. So what are you going to do? Are you going to make hospitals that are lean and cheap, or are you going to make them expensive and fancy and nice? So, but is there a silver lining here? Is there one solution that, if strategically created, it does provide the value instead of the cost angle, the value for the business perspective to really run after providing these quality experiences for the patient? Just because, well, guess what? If they provide a more private rooms and patients are easily communicating, the medical errors and misdiagnoses are reduced, their lawsuits are reduced, and you have a business case right there. And if you have data to show it's a win-win, that may be the path for change. But one thing, Pete, you mentioned that we can't really, it is what it is. And sometimes the best solution is one that's hardest to apply. It has the most long-term benefit, but it's really hard to bring the stakeholders together. And that's why, in a matter of practical perspective, sometimes those solutions, those who have social ROI, external ROI, may get a little delayed, and those who have easier low-hanging fruit will become the path to change. But just acknowledging that your point about change and the most important things sometimes get clogged in the system.
Thanks, Rana.
Yeah.
Thank you.
So I think we're way over time here, so I think we probably should finish up unless somebody has immediate questions. So thank you very much, Rana. Really interesting talk. And I'm going to try to connect with you about some of these ideas later, but by Zoom, I guess. Okay.
Great.
Okay. Thank you all, and have a nice day. Bye-bye.
Thank you.
Thank you so much.
Yeah.